the Operation Theatre Complex at Drishti Eye Hospital, Dehradun. And it's my honor to introduce the two pioneer surgeons, Dr. Gaurav Luthra and Dr. Saurabh Luthra, joining us live from Dehradun at Drishti Eye Hospital. We can see you, sir, dressed, washed up, scrubbed. So waving hi to all of us, and it's an honor to see Dr. Gaurav and Saurabh, the combo together. Often we see one in VRSI, other in IIRSI. That's great to have you both out together, and it's a proud moment for Kanpur Ophthalmic Society. So to have live surgery seen under Dr. Gaurav Luthra, no need of introduction to the brothers. They are pioneers from Uttarakhand and have raised the Indian flag high across the globe. We see him presenting at the AO, IIRSI, and AIOS, ESCRS, and ASCRS, and whatnot. All societies have presentations and publications inscripted by Dr. Gaurav and Dr. Saurabh Luthra. Gaurav Luthra, sir, is a pioneer and a doyen of ophthalmology, anterior segment surgery. We have seen him operating, we have seen him presenting, and his interesting cases as far as refractive surgery and cataract surgery is concerned. And Dr. Saurabh Luthra has been training, mentoring, and doing complex vitreoretinal surgeries for more than 2 decades. He's an alumni of Shankar Nethralaya Hospital, Chennai. And without wasting a second, I would like both of them to start the surgical procedures and introduce the kind of work they are going to do just now. Welcome both of you, sir.
Thank you so much, sir. I hope I'm audible. Am I audible there?
Yes.
Great. So first of all, we would like to thank Kanpur Ophthalmic Society for giving us this opportunity to, transmit live surgery from our OT complex. And as requested by Malay and team, we are all set with one cataract surgery patient who's already draped and ready. And after that really interesting talk from Dr. Rasik, which really showcased what is the review of literature for femto. We now have a patient lined up for a phacoemulsification and a topical anesthesia. I'll request Dr. Abhijat to please showcase to share the screen for you of this patient's details. Can you go on slideshow? Yeah.
Yes, we can see your slides.
Would you like to present it?
Yeah, am I audible?
Yeah, quite bold.
Okay. So a very good morning to everyone. So today we'll be discussing here and we'll be showcasing a live surgical fiesta in which the surgical components will have two parts. So the initial part would be a live cataract surgery, which will be performed by Dr. Gaurav Luthra, who's a director at Drishti Eye Institute and a cataract and refractive surgeon. So before going into the surgery per se, I would just like to show you the brief summary of the patient. So the patient is a 68 years old female who had complaint of gradually progressive diminution of vision.
Somebody is speaking on the movie.
Yeah, we could switch off the mic of other speakers for the time being. Yeah. So the patient had complaints of a gradually progressive diminution of vision in the right eye since 4 months, and the patient is a known case of hypertension. She also underwent cataract surgery in her left eye in September 2021 at Drishti Eye Institute itself. So her ocular examination was mostly within normal limits, except her uncorrected visual acuity in the right eye was 3/60 and was correcting to 6/24 with pinhole. Her intraocular pressure levels were normal, and her extraocular movements and the rest of the anterior segment examination was basically within normal limits. Her pupil of both eyes were round, regular, reacting. The right eye showed a grade 2 nuclear sclerosis cataract. However, the left eye was pseudophakic. The fundus examination of right eye revealed a dense asteroid hyalosis, and apart from that, both eyes had a normal retinal examination. So on viewing the lens star biometry of the patient, in right eye, we can see that the axial length is at 22.59 millimeters, and she has a normal anterior chamber depth of 3 millimeters. The K1 and K2 also have a nominal readings, and we can notice that her astigmatism Astigmatism is very minimal. So therefore the patient is planned for a monofocal hydrophobic EDOF IOL, and her biometry and the lens value comes out to be 24 diopters. So the plan would be a right eye phacoemulsification with foldable hydrophobic acrylic EDOF IOL. So now I'll be switching over the mic to Dr. Gaurav Luthra back to continue with his surgical part.
So as I start to it, am I audible?
A bit. Can you speak? Yeah.
So
Mic.
this is how we kind of lay out everything, because we do a lot of torics as well, and today we are not doing a toric. We would usually have the patient sheet, and we would have the Lenstar and the ILMaster 700 readings, and we would also have the iTrace and the Virion readings. That helps us look at all the astigmatism on the various machines and helps us do the toric planning in a better way. And it obviously gives us all the data on immediate reference, what is to be used. So we normally use Virion guided surgery, but today, of course, there is no indication for that. So I'll be starting off now, and during as we go on, if there's anything, I will be happy to discuss. Can we switch the view to the microscope?
So Dr. Dharmendra is sitting with us. He is also an elegant phacosurgeon. So I will.
Dharmendra, sir?
Dharmendra ji hai sir.
Wonderful. I've operated in his OT, so it's a wonderful, you know.
एक आपको दे रहा हूँ. ये लाइव सर्जरी के बहुत शौकीन है सर, आपको पता है.
So I think
डॉक्टर तिरुपति की अगली दो नाथ में.
is the view good enough? So we'll do a quick registration on
Gaurav?
Virion. We've done the registration, and you can see that it's showing me what the incision location and everything is. And I will be using, can we switch on the Virion for a moment? I wanted to show something. While Virion, of course, and femto-assisted surgery and everything is great, you know, when you don't have access to all these things, it's still important to get your things right. And you can do it very well without, you know, depending on very expensive instruments. So I use this Rexis marker, which kind of indents. This has been improvised by me, and I'm using it for almost 10-15 years now. It leaves a very, very fine indentation on the cornea for just about a couple of minutes, and you can make a Rexis. So here we are using, these are special blades. These are 22 gauge money blades, and there is no financial interest, but this gives me a perfectly sealing incision. So it's a calibrated incision. So this is one side port for my side port instruments, and this is the other one. Even my choppers and all are kind of calibrated to this size so that I don't have leaky wounds during surgery, and my chamber stability remains perfect during the surgery. The lady has been actually draped for almost 35-40 minutes now, so she may be a little restless. We'll just see how it goes. So a little bit of intracameral lignocaine. I don't put viscoelastic at this point, and my main incision is usually made either temporal or at 135, depending on which I am operating. And here, this is a 2.2 incision, and this is again a money blade, which I really enjoy. I've used all blades over the last 25 years, and now last 5 years or so, I'm on these blades, which are actually better than my diamond blades that I used to use. The AC depth, internal AC depth is about 2.5, so it's just enough. It's not a very shallow chamber. You can probably see a lot of asteroid. The patient has been warned about, you know, the asteroid hylosis. आप लाइट में देख रहिएगा माँ जी, बस दोनों आंखें खुली रखिएगा, हिलना नहीं है. So this gives you a perfect 5 or 5.1 or 5.2 Rexis as you would like. If you run right along this Rexis line, I don't know if that line is visible. Dr. Malay, Dr. Dharmendranath sir, is the line visible of the Rexis marker?
Yes, it is little visible.
Okay, so I'm running right along that line of the indentation, which came from the Rexis marker. If you would like, I can zoom in a little bit. So I'm running right along that line. It gives you almost like a femtorexis or a zeptorexis. So see, it's beginning to kind of run out a little bit, so I'm bringing it back in. So we got almost a perfect 5 millimeter rexis. I'll just show you the Virion also. Virion on color. So you can see that the Virion is showing exactly the same marking. So I was just wanting to show that with Virion, what you get, or Callisto, you can get exactly the same thing with the Rexis marker, which just costs 2,000-3,000 rupees, and you can use it for almost like 10 years. One Rexis marker will last you a long time. So once this is done, we are now going to just do a small hydro. You can lift up the edge of the Rexis a little bit and push a small gush of fluid. I use a 1 mm 1 cc syringe, because using a bigger syringe will cause more pressure and can cause issues. And then I'll just release some of the extra fluid and rotate the lens, the nucleus. So now we are all set for the next stage of the surgery. So if you look at my chopper, it is, while it's hilna nahi hai Maji, aapko aaram se letna hai, it becomes wider towards the end, so it kind of blocks the incision of 22 gauge. बस आराम से लेटे रहिएगा, अभी बस आधा हो गया ऑपरेशन आपका, आपको बस हिलना नहीं है अभी. We are planning to use eye hands lens for this lady. She has been complaining that can I get better near vision in my other eye? I have no near vision in the other, in the first operated eye. So since we had the benefit of the live surgery, and Johnson & Johnson was kind enough to help us with a lens, we are going to use an eye hands lens, which is one of my favorite lenses. Now I use them in very big numbers. In fact, my monofocals have gone down and we use more of the EDOF. I'm doing a direct job. So embed and then track. And lateral separation. And you can see that there's almost no fluid escaping from my ports. So the chamber. हिलना नहीं है माजी, आराम से लेटिए. कोई तकलीफ होगी तो बोल दीजिएगा हल्के से, हाँ? She's been lying for a long time. We have our pieces now. I like to make about 4 to 6 pieces depending on the hardness of the nucleus, so that we can be easily removed. So modern machines are excellent. You can operate with very low fluid pressures. On my Signature Pro, I use a bottle height of just about 40. On the you can also between 40 to 60 depending on what I'm doing. So the fluidics are excellent, and the fluidics of even a normal machine can be improved if you are using incisions which are calibrated to your instrument. So most often I see that people pay a lot of attention to their main port size, which is matched perfectly to your tip and sleeve, but people don't pay attention and they can use a 15-degree blade or something else which will give a big side port, and that will keep leaking throughout surgery and through the chopper port or from the bimanual port, and you will have a chamber which is constantly fluctuating. So there has the cataract gone. And now I hope the centration and everything is fine, Dr. Malay.
Yes, its centration is fine. It is so absorbing actually. So flawless actually. We didn't have, I think, no any question. Dr. Dharmin?
I think we don't require any questions from Gaurav Luthra already. He's explained so nicely that every step is so clear that we don't want to disturb him during the operation. He's explained by himself because he's a nice, wonderful operator all the time, and as well as he explains everything, every step very nicely. So there is, I feel everyone can understand very well.
Dr. Amit, you want to make a comment? Yeah.
Dr. Gaurav,
This marker which is used on the cornea. Now the cornea is curved. So what was the size of the marker which you used, and how much magnification do you accept on the anterior capsule when you mark?
So what I didn't actually, the audio from your end is a little it's not very clear, but I heard that you talked about the corneal indentation mark, is it? So this rexus marker is actually calibrated so that you will get a rexus size of 5 millimeters. I think that's what you wanted to know, right? So on the anterior capsule, what you will see on the anterior capsule is going to be 5 millimeters. So if you want a slightly bigger than 5 millimeters, I'll go just outside the marker. And if I want it exactly at 5 millimeters, and I never want it smaller than that most often. So if you want 5, you will go run right along the mark on the cornea. And if you want it a little bigger, like 5.2 or something, you can go slightly bigger than that. So it gives you a well-centered and a perfectly round and a perfectly sized. So 3 things: perfect size, perfect centration on the visual axis, and also a perfectly round rexus. So I hope I answered your question, because your audio is not perfectly audible. It's not very clear.
About the magnification factor. Now your rexus marker is giving you a size of 5 and 6 millimeter rexus. But what is the size of the marker? Because the cornea is convex. So
Okay,
when
Amit, I
you
got
mark,
your question. The magnification factor has been taken care of so that your rexus size is 5 millimeters, as you saw with the virion overlay of 5 millimeters. So I cannot tell you the exact size of my rexus marker because that's made by Epsilon people, and I won't know exactly what they make. But I have tested it out with the virion that we get an exact 5 millimeter mark. As the virion shows a 5 millimeter rexus, this shows me exactly the same. That's why I showed that it becomes almost identical. But I won't know the size of my rexus marker. Obviously, it will be a little different. So here we've managed to get the cortex out. Now, if you look at my irrigation aspiration handpieces, there is almost no leakage of fluid. You can look at my left one, the irrigation one. There's a small hemorrhage lying over there and which is not moving. So my side ports are perfectly sealed. There is no fluid escape at all at any point. And this gives me a very, very stable chamber during irrigation aspiration, even with very low bottle heights. And, it becomes very comfortable. Also, if you'll notice, these are both sandblasted. Both my handpieces are sandblasted. They are very finely sandblasted. So if I have to do a polish, I will just go and do a polish. I'll just show you how I would normally do it. Like if you can probably see, there's a minimal plaque right in the center. So I will go from the main port and I will go very close to it with my infusion handpiece so that the fluid is running. So I'll just go like this and I'll go and kind of do a jet polish. And this helps me in because it's also sandblasted and the fluid is constantly flowing. I'll just go if there's any irritating piece of cortex or a plaque stuck anywhere or even in the bag, somewhere if it is there in the equator. And this patient has a lot of asteroid, as you can see. So we are all set with the implantation of the IOL. There is almost no astigmatism for this patient. I do a hydro implantation. I don't use viscoelastic for maybe last 7, 8 years or 10 years. Even my eye cells are all implanted under infusion only now because I don't like viscoelastic to be in the end of surgery be left behind in my port. So here we are injecting an eye-hands lens. You can see I'm doing wound assisted. And my assistant is adjusting something on the machine. I'm just going to wait. So I'm sorry about that. So this is implantation into the bag. And then I will just, so you can see that all this was under infusion only. And I did have to, for some reason, apply a little extra pressure today. The IOL was probably loaded without 1 drop of visco, which is usually put into the cartridge. That's the only drop of visco which usually escapes with the fluid. So as I'm injecting the lens, the fluid is continuously flowing. Now you'll see that I've implanted the lens in the bag and my infusion is still on. My globe is still well centered. So this is stabilizing the globe and I can stabilize the globe. And even without removing this, I will now seal my side ports. And these are Herschel-Tuck cannulas, which I'm using. I started using them about a year back. They're really nice because they allow me to seal all the ports very easily. So they go inside the incision and so sealing the incision like this is very good because your IOL will not move, your chamber will not get shallow. So if you're doing torics, like I said, I do a lot of torics. So my toric stability will be perfect. It will not change. The lens will not rotate inside. And then this is the wound is sealed. Trypan blue, Lily. So I use trypan blue for a different purpose. We don't need to stain the capsule, but I'll show you. Now my main ports seem to be well nicely sealed. And now I'll just seal the main port. So this basically being a very small side port, the chamber will remain stable most of this time and maintains very good chamber stability. I think we were at Calcutta, Amit and me were in Calcutta last week for that live surgery where Amit did an excellent live surgery as well. And we had a great session of learning there. So here I'm going to show you what I do to check my ports. I don't do it for every patient, but if you're having a leaky port, you just put a drop of trypan blue. I've again been doing this for 5-10 years. And I think this was probably something that we had innovated and reported. So you can check for any fluid. So if you notice, there's no leak here. There's no leak here. But there is a minimal leak over here. Can you see this? I'll just show you again. If you look at my side port, so I'll just put a drop of trypan blue and you'll see a stream of aqueous coming out. Now in pediatric cataract, I started by doing this in pediatric cataracts and I now do this for any patient who has a leaky side port and I can then go back and seal this if I have to. So there I go again. And then intracameral moxifloxacin. Again, this is something which I've been using regularly now for about last 4-5 years, ever since the Arvind study came out and even before that. And we use pre-filled moxifloxacin. We do this for every patient, and I believe in some cases even Dr. Saurabh has started using now in retina. So there was a expert group meeting of AIOS last week at Delhi, where it was discussed threadbare, and it was found that this does have major advantages, and that publication should be out very soon. So intracameral moxifloxacin 0.1 ml. We are using 4-quin from Entod. Again, no financial interest, but the quality has been excellent over the years. So with that, I think my surgery is through. We can switch out of the...
Important points which I think the audience took was basically your X is marking, it is a very important thing. Then coming to your PC polishing with the hydrojet. And last was checking the leaking wounds with refined fluid. These are 3 important points I think which gives a take-home message to all the audience who are not practicing this. Is a very important tip and well demonstrated surgery, Gaurav.
Dr. Gaurav, till Dr. Saurabh is washing up, make a comment about your lens which you have put.
Okay, so we've used the iHands lens, which has, as I said, it's become one of my favorite lenses of late. We have decreased our monofocals because it's a very forgiving lens. Patients are very happy with their intermediate vision. It's not expensive. There are no risk of halos and glare with this. So post-refractive surgery, anybody with a little bit of retinal pathology, patients with compromises, other than that, like, I do a lot of RP operated patients. Also routine patients who are not keen. There are patients who would want some kind of near ability, but are very scared. They've heard of halos and glare in multifocal lenses. So many of these patients, they do extremely well with this iHands lens, and we do a micro monovision. So in one eye, we go aim for a plano, and in the second eye, we aim for a -0.5. These patients are able to do 90%, including one of my close relatives whom I had operated. He's heavily into the stock market, and we reported this case. He came, he's a hyperope. We did iHands for both eyes. He didn't come back after his both eye surgery for his glasses prescription for almost 3 months. I kept calling him, and I found out that he had been seeing the stock market on his phone and his iPad regularly for 3-4 months. Finally, when I called him back, he says, I'll get my glasses made. He's not using them. So anyway, every patient will have a different experience. The ad is very small, so don't expect any patient. We don't tell any patient they'll be able to read really at this range. But I typically tell them that, if you hold things here and with good illumination, you'll be able to see at least something, you see your watch, you see your phone. They usually do better than that. So, giving less expectations and letting them experience little better results is always better. So I think we've had a great experience with this lens actually.
I think we still have some time. Dr. Muscati, sir, would you like to make a comment?
I'm fine. Gaurav, I enjoyed it all through.
Good morning, sir. A pleasure to have you in the audience. I'm lucky. So I think we'll pass on to retina if there are no other questions. Saurabh is ready with his.
Gaurav, you think EDOF lenses like this, like ions could be safely put after SICS also?
I'm sorry, sir. Can you just ask again?
Could these lenses be used after SICS surgery also if the rexus is good?
Absolutely. I think if the astigmatism is taken care of, and I wish they had a toric version which is supposed to have come like almost many months back. But if there is astigmatism is taken care of, I don't think there's any problem in using these lenses. In fact, they are less, they are more tolerant of a little bit of astigmatism than multifocal lenses. So in that sense, with SICS, especially now that our SICS surgeons do excellent surgery with almost no induced astigmatism, I think it should work extremely well. Definitely.
Thank you.
So, Dr.